Okay, so our next speaker is Dr. Kalpana Babu Murthy. She's the head of uveitis and ocular immunology services at Prabha Eye Institute and Vithala Eye Institute in Bangalore. And she's also the current president of the Uveitis Society of India.
Thank
Over
you,
to you.
Chairs. And I would like to just continue on where the previous speaker had left with these interesting cases. So this is my first case, and this is a 62-year-old lady, and her only problems were diabetes and hypertension, who had had a cataract surgery in her left eye. And then she was diagnosed as Irwin-Gas syndrome, and she presented to me for a second opinion. So when she came here, her right eye had a mild inflammation, and if you can see the blue arrow, there is a medium-sized keratic precipitates, and both eyes, the vision was a little on the lesser side. So now it was clear that we were dealing with a granulomatous uveitis, and so we did a fluorescent angiography just to confirm if there is an inflammation going on at the back. There's a lot of leakage in the vessels. CME confirmed both on the FFA and on the OCT. So we went through the granulomatous workup, and this is where I would say the CT is so important, because though she was asymptomatic systemically, her lung was pretty bad. She had mediastinal hilar lymph nodes and a lot of changes, subpleural nodules in the lung. So when we did the workup, she had lymphopenia. Her ACE was normal, probably because she was on anti-hypertensive medications. Her MAN2 and quantiferon was negative. Generally, we always do a biopsy in conjunction with the pulmonologist. This was a non-necrotizing granulomatous inflammation, AFB negative, gene expert negative. So everything fitted so well and so beautifully as sarcoid, and we started her on steroids. And usually what we do is we wait for the culture before we start immune suppression. And lo and behold, what we see, the culture grows Mycobacterium fortuitum, and our whole treatment changes completely. And now she's on anti-tuberculosis drugs, and along with amikacin, linezolid, and moxiflox. So when we look at criteria, which I usually devised for ocular sarcoid, and if you see, everything fits into sarcoid, but this is actually an atypical mycobacteria, which is presenting like a sarcoid-like reaction. So for me as an ophthalmologist, I think that CT and the biopsy is something which is very, very crucial in a in a country like ours, which is so highly endemic for TB. And this also goes to say, when we call our patients sarcoid, I think it's always important to keep even atypical mycobacterium in mind. My second case is a 30-year-old female ophthalmologist, and who was diagnosed to have punctate inner choroidopathy. And she came to me with a distortion in her right eye in November. And she had past history of recurrent CNVMs, almost 12 injections, and then she moved to UK. But all along, she's never had vitreous cells. Her old FFA shows no signs of any vascular leakage, retinal vascular leakage, or disc leakage. And she was also investigated, and except for a quantiferon TB Gold, which was positive, all her tests were negative. So this was the first presentation in 2019, just scars here. And she was treated with anti-VEGF. And then this is 2020. And this is when I saw her in 2022. And definitely things are progressing. And her left eye also, she started having these lesions which was there, and they were very silent with no vitreous cells. So initially we also thought it's punctate in a choroidopathy, but then the fact that she kept getting recurrent CNVMs, we thought let's just investigate her a little more. And this is in January when we saw her. So at this point of time, we said, let's do a HRCT. And we were horrified when we saw pericardial effusion, pleural effusion, and she had bronchiectasis changes in her middle lobe as well as the lower lobe. And according to the radiologist and the pulmonologist, they felt that this is very typically seen in atypical mycobacterial infections. And so she underwent a lavage. Again, if you see, her PCR on the lavage was negative, cytology was negative, there was no granulomas, but the culture grows Mycobacterium chimera. This was something very new to me also. So we discussed with the ID specialist, and he said this was a classical disseminated Mycobacterium chimera intracellular infection, and she was started on these medications. So these are two cases which, and ironically, after she was started on anti-TB medications, she develops a paradoxical worsening, and this is the first time we saw vitreous cells in her eye. And we had to start her on oral steroids with anti-TB medications. So we are still to see her follow up because she's gone to the UK back, and she did reply that she was doing well. But from these two cases, there are things which I have learned. We've talked so much about TB since morning, choroiditis and everything. I think in a high TB endemic country like ours, it's always important to rule out mycobacterial infection and not necessarily only typical, even atypical. And these are clinical phenotypes, sarcoid, PIC, and these are things which I think you should rule out a bug. And atypical mycobacterial species may be more common than we think. And I think for us, it doesn't end with indirect evidences. I think we should look at biopsy-based diagnosis in future, as we do have the technology to do that, and attempt it whenever possible. Thank you.
Thank you, Dr.
I would
Kalpana,
just
for
like
presenting
to
this
just
challenging
add,
cases and managing it very well.
yeah.
Yes, whenever we see a patient, the first go is diagnose tuberculosis, we put them on anti-TB drugs. And then if they are not responding, they are worsening, then we'll go about investigating it further. In your case, you're fortunate enough, the biopsy, the
Yeah.
culture grown atypical mycobacteria, and the treatment could be straightforward. So when you have a patient, for the benefit of the audience, you suspect tuberculosis, you start ATT. If there is a worsening, when do you suspect or how do you differentiate whether it is paradoxical worsening or drug-resistant TB or it's atypical mycobacteria? Can you give us the guideline?
Yeah. Actually, unfortunately, we do not have any guidelines so far with respect to atypical mycobacteria, but definitely paradoxical worsening is something which we usually see between 3 to 6 weeks. And drug resistance usually, I mean, you wait for at least 3 or 4 months, and you look at how the frequencies are. If your frequency of inflammation is coming down, and or it's not working at all, then it is important to look into cytology and microbiology. But I think now the technology is so advanced that probably I think if you can do it in the initial stages, like in these cases, and HRCT is now available almost everywhere, I think you will save a lot of trouble in terms of drug resistance if you're looking at, because they do investigate the drug resistance as well as in the sample.
Thank you. I would like to get Dr. JB sir's comment.
I'm more familiar with the usage of PCR for these tissues, PARP sections for diagnosis.
Unfortunately, I think the PCR, I mean, it's also, as the previous speaker in the previous session had mentioned, I think the institute-based PCRs are different. Commercial-based PCRs generally have a very low sensitivity and specificity for tuberculosis. And even in all these cases, the cultures have come positive, but the PCRs have all been negative. It's very ironic, actually.
Sure, and also we can say atypical mycobacteria is present or not. We may not be able to get the subspecies what you have,
Correct.
either like 42 more.
The only thing that holds us back is the exorbitant cost of the EBIS,
Right.
the endoscopic guided biopsy of lymph nodes. Is a pretty
But I think the point to be stressed is I think we should move on from chest X-rays to HRCTs, actually.
Another thing in my experience, I've also seen patients with getting optic neuropathy with linezolid. So have you had such experience now that
No,
we use these
fortunately,
other
we have
drugs?
not had with linezolid, but we have with the ethambutol. It is
Ethambutol we know,
increasing
but
quite a bit.
Another drug that we need to keep in mind is linezolid. So if the patient is on these drugs also and developing vision loss, then do look at linezolid.